sure you're in the right place. We are going to talk about partnering with others to improve behavioral health access. And before we start, I just want to make it clear that none of us have the magic bullet answer. So if you came here looking for that, I'm sorry. We're not going to give you that. But we do have some great examples of some innovative things that are happening across our state that I think you will be able to take back and use in your communities too. So just as a way of introduction, my name is Jennifer Fenley. I work at the Kansas Hospital Association. I'm going to serve as your moderator today. We have 3 different panelists with us, and so after we do a quick introduction and some level setting, I'm going to introduce you to our panelists. They each have some prepared comments that they have put together to talk about things that they're doing, and then we just want to open it up for a discussion. So I really hope that you all will jump in and engage with us. It'll be a lot more interesting for all of us if we have some give and take from the audience. But just to kind of level set, I think we all know that there is a mental health or behavioral health problem in our country. But I will admit, as I was gathering some statistics to kind of introduce this panel, I was dumbfounded at some of the current statistics that are out there. Things are worse than even I realized. So there is a report that is put together by the Mental Health America Group, which is a nonprofit organization. They do a lot of public education, advocacy, and policy work in the area of behavioral health. They produce a report every year called The State of Mental Health in America. It is the premier report that folks look at to get kind of a read of where things sit. Their 2024 report states that over 23% of adults report that they have experienced some kind of a mental illness in the past year. That's across the entire country. But we are a sample of the entire country, so my guess is that if we were to pull data specifically for Kansas, we would find very similar statistics. They also go through a process where they rank individual states, and they look at a variety of different factors. So on top of 23% of folks reporting that they have experienced some kind of a mental illness, which actually equates to 60 million people across the country, which I thought was a pretty staggering number when you look at it from that perspective. More than 5% of the people in the United States, 12.8 million people, report that they have considered suicide within the past year. Again, another alarming statistic. It's something that we hear about, but until you put real numbers to it, it wasn't as real for me. And then 340 people. It takes one, or I'm sorry, let me rephrase that. Sarah showed you a map earlier of what the provider shortage looks like in Kansas, as far as what areas have access to a mental health provider, what areas might not. When we look at that across the country, we only have 1 mental health provider for every 340 people in the United States. So we're never going to solve this problem if we just look at trying to increase the number of mental health providers. It's an uphill battle. So we have to start looking at other kinds of solutions. And as I said, this report does look at a variety of different factors and try to create some rankings so that you can get some perspective of a state as to how you compare to, say, other states. So this map shows their ranking of states. If you are a very light colored, you're ranked 1 to 13, and then all the way over to the very, very dark areas includes 51. So they ranked 51 states. I'm guessing that means that they included Puerto Rico or something like that in their rankings. And this specific map shows us access to care. So they look at a variety of statistics or a variety of factors in their definition of what it means to have access to care. They looked at your access to insurance, your access to treatment, your access to quality and the cost of the insurance, the special ed workforce that you have in your state. So they're looking at both adults and children when they look at this access ranking, and what the mental health workforce looks like. So a 1 means that you're doing really well, and 51 means you're really, really bad. and we're kind of right in the middle. Kansas ranks 35. So while they showed that we had a prevalence of mental health, our ranking for prevalence of mental health needs was at 19. So we don't have as many folks in our state as some others needing access or reporting that they need access to care, but our access to care for those that do isn't so great. So we're kind of right there in the middle. We have improved compared to a couple of years ago. So we are making gains in this area as a state, but certainly have a lot of room to grow. And then if you want to look more specifically at your region or your county, or maybe even your zip code level to see how your specific area is doing, I wanted to make sure you knew about this map that's available through Kansas Health Matters. We've talked about this tool a couple of different times during the conference already. There are a variety of different parts of Kansas Health Matters, but there is a new section that they call the Mental Health Index. And this is an index that they have created that is a measure of socioeconomic health factors correlated with self-reported poor mental health. So they try to look at both sides, what may be contributing to some of the poor mental health. They look at things like disability, your employment status, your access to healthcare coverage, what kinds of insurance you might have. Are you a single family household or single parent household or a multi-parent household? And do you have access to transportation? Those are the key factors that they rank within this bigger index rating. And what this map shows you is the areas that have a higher need compared to other parts of, say, your county or the state as a whole. So the darker the color, the higher the need or prevalence of mental health issues along with these factors. So if you are going to take services to a specific geographic area, this map would help identify those areas that may have a greater need compared to others. Now you will also notice there's some gray, white areas on this map. That means there wasn't enough data available to really rank it. So it doesn't mean there aren't issues in those areas. It just means we didn't have the data to put a specific rank on those issues. They take each zip code within our state and have a scale of 1 to 100 and rank them with a score, literally 1 to 100. And if you click on this map, you can start to see each zip code listed and the specific rank that each zip code is given. And then they compare each zip code with others in the region, and that's how they come up with this ranking of 1 to 5. Lots of detail if you dig into it about how they did these rankings, and I generally say let's not get so wrapped up in all the scientifics behind how they did it. It's just a way to know how to focus some of our resources and where the areas are that might have a higher need. If you're looking at serving a particular area of the state, might help inform some of your work. So these are just a couple of pieces to kind of set the stage of where we are as a state. Certainly we have issues, there are things that we need to address, but what I really want to be able to jump into is how some of our communities are already working to address some of the challenges that are facing our state. So we have 3 panelists joining us today. Lisa Southern, who is the Executive Director of Compass Behavioral Health. Carla Hermish, who is the Director of Social Services at Nemaha Valley Community Hospital and the Seneca Family Practice. And Yasmin Wood, who is the CEO of the Legacy Regional Community Foundation, which is in Winfield. So I've asked each one of them to share a little bit, also to give you a little bit more background about them, their organizations, and to share some of the things that they have been doing in this space. We'll let each one of them share with us the work that they've been doing, and then we want to open it up for more discussion. We're going to start out with Lisa.
Trying to get organized up here. Hi, Compass Behavioral Health is a community mental health center in Southwest Kansas, and my particular mental health center covers 13 counties, okay? Just a little bit about myself. I just celebrated my 30-year anniversary at Compass. I've held a couple of different positions during that time. My current position is as executive director, where I have been for 7 years. I am totally devoted to Compass, And after listening to Jennifer and talking about how we always say hashtag saving lives, we obviously have a lot of lives to save out there with mental health treatment. So I will say definitely when it comes to mental health, it is never boring or stagnant. There is always change to be made, and there is always something happening. So where exactly is Compass? We have 4 different regions. There are several multi-county community mental health centers in Kansas. And, well, let me just go this way. There's 26 community mental health centers in Kansas, and there's probably 26 different ways that community mental health is managed in those centers. So we have 13 counties that we're responsible for. We started in 1961, and the way we manage it is having 4 independent regions. So each of those offices that covers either 3 or 4 counties is a fully operational office. This way we can reach all 13 counties very quickly, rather than having just like maybe one office in Garden City, and we're 2.5 hours away from our furthest community, which would probably be Elkhart. In our 13 counties, we are responsible for 109,000 lives. In those 13 counties, we have 10,917 square miles that we cover. So it's a very large area. We are mostly rural and frontier. And yes, we do have our fair share of tumbleweeds. To accomplish this, we have approximately 200 vehicles that are constantly on the road. It's the only way to take care of people. We have found if you just rely on people coming into your office, you're probably not going to see them as much as you need to or as much as they need. So we are extremely mobile. Earlier question about CCBHC, we did just get our full certification. All of the 26 centers are at least provisionally certified. So when I talk about services today, these are services that you should find if you are located in the state. Again, there might be 26 different ways these services are provided, but we are all required to provide the CCBHC services. And I'm going to show you a slide of that here in a minute. Right now, okay, so before we became a CCBHC and really grew, my last 15 years probably at Compass, we've had 200 employees. In the last 18 months, we've grown to 323 employees and grown from a $14 million budget to what's going to be at least a $24 million budget next year. Okay, these are the 9 core services that are required to be provided by any center that is going to be a CCBHC. And again, everyone is at least provisionally certified. So if you see a service up here, you should be able to help refer people to get that service. So as a CCBHC, and especially as one that is in a rural area, I see that we have 3 choices every day when we come to work. We can provide what is needed, we can coordinate care and get people what is needed, or we can create what is needed. And that is what Compass does. Care coordination and partnerships are extremely vital to providing services to everyone in need and to ultimately save lives. So an example of each. Well, you saw the 9 services. We can provide all of those 9 services. Coordinate care. Well, we can't provide healthcare services. We're not able to do that. Also, we have a very tough time in Southwest Kansas providing drug and alcohol services. At one point, it was stated that 10% of the people that are licensed as addictions counselors live in the entire western side of the state. It's not very many licensed providers for us to access, but with Zoom and telehealth, we've been able to do a little bit more. So we coordinate and find what people need. The other is to create. So if we don't have a service, then we create it. And we've done a lot of creating with services for veterans. And then the mobile crisis that we've created, because I think crisis services are probably very important to everyone in this room, and especially mobile crisis. So that's kind of more of a focal point of what I have for today. But our crisis services are 24/7, 365. Christmas morning, we're going to be there if someone needs us. And with families getting together at Christmas or any holiday, sometimes that's when we're needed more than ever. So during business hours, there is full access to crisis services. Then after hours, we have 3 therapists on call at all times to cover those 13 counties. Now, we can't drive to 13 counties necessarily, but we know our heavy pockets where we have more crisis. So Dodge and Garden for sure have access to a live therapist. And then our other counties are pretty much covered either by travel or by televideo. Also, we added having 4 support staff on call at all times. So let's say I'm in Scott City and I'm covering crises for Ulysses, which would be approximately an hour and a half away. I have a case manager on call for the Ulysses region who can go and be with that person live and help with that Zoom assessment if I need it. If I'm on call in Scott City and an hour and a half away, a parent calls and says, somebody's got to get here fast. Send the case manager over there. Our goal with this is we want to keep people out of unnecessary emergency room admissions, which is where a lot of people think they have to go if they have a crisis. And that's not necessarily true. We also want to keep ambulance and law enforcement from having to respond to a home. So if we can go to the person instead of having one of those entities go and bring the person into the emergency room, that is definitely our goal. The crisis is always defined by the person. We've had crisis calls where a kid melts down over what was served for dinner. Well, we know what was served for dinner is not the crisis. It's everything else that happened that day or the week leading up to it, and that was the final straw. So 100%, and this is not just a Compass rule, it is a CCBHC, CMHC way. The crisis is defined by the person. Okay. So what are some obstacles then we have with our crisis services? Well, last year, Compass did 1,848 crisis services. 939 were minors, 909 were adults. We had an 85% hospital diversion rate. So we have built an infrastructure to try and find ways to give people resources and supports without having to hospitalize. Because inpatient treatment from Southwest Kansas for kids is going to be a 3 to 8 hour drive. That's one way. Then we got to get those kids back to our community. And for adults, it's a 4 to 8 hour drive. Also, we can't rely on state hospitals anymore. They don't take voluntary admissions. And sometimes people are sitting in an emergency room for 6 to 16 days. What we do during that time frame is we work with the ER doc to get that person on meds. We have a therapist go in and see them daily, and we have a case manager who stops by a couple times a day to check on them. And we have had people that we've been able to safely discharge from there instead of having to wait for that bed to open at the state hospital. So other opportunities that we have is open access. You know, if you need mental health services, you just walk in and we're going to give you some sort of service for the day. We also, to help with intermediate care, rather than have to do a hospitalization, we have both an adult and a child crisis house. We also use the Children's Crisis House for respite. So we have a family that's at risk for a child being placed in foster care or a foster family, and they're about ready to give up on this kid. It's like, what kind of problems are you having? Okay, Monday through Friday they go to school. We'll take them every weekend at our crisis house. Give you a break so you can devote time to your other children that are in the home. And that does typically help. We don't have a lot of foster care kids in our area, but it can help preserve that foster home placement. Let's see. Our person in crisis is always, of course, our primary focus. So who are our partners? Well, really everyone is our partner. We succeed or fail together. I was just at a conference and they said, if your partner fails, you are failing them in some way. And so I immediately went back and I talked with all my staff about that. They are not our partners so we can use them for what we want. They are partners with us because we're supposed to be mutually helping each other. We had to grow our partnerships to be a CCBHC. We all had to come together and realize that we are stronger together. Do we have competing priorities? Yes. Do we have disagreements? Yes. And in the end, we all agree we care about people in our community, so we're going to find our way around those disagreements and we're going to help people.
Thank you.
Hi, everybody. My name is Carla Hermish. I'm a social worker for Rural Care Access Hospital in Seneca, Kansas. If you don't know where that is, it's a very small community in northeastern Kansas along the Nebraska border. This is a little bit about me. I went to school at Washburn and received my social work degree, and I didn't really know what I wanted to do with it. I went back and forth a few times, and then I landed in my hometown. Very thankful for that, to be able to work and grow our community. So this is a picture of our hospital. However, it's a work in progress. It doesn't currently look like that. We are expanding it, and I'll tell you a little bit more about that here in a little while. So Nemaha County's population is roughly about 10,000. There are 2 critical access hospitals in Nemaha County, including Sabetha Hospital. And today we're going to talk about the barriers to our community receiving the mental health resources that they need in order to thrive and what we need to do to help. So here are a list of our local mental community health providers. Kansa Mental Health is our main mental community health provider, and they provide a multitude of services, including individual therapy, case management, med management, and crisis services. Recently expanded into home support, such as the mobile crisis unit that was discussed earlier. We lean on them for a lot of services for our patients in crisis, and we are very thankful for their partnership. However, regardless of where you are, I know there are wait lists. Today, we are going to be talking about Nemaha County and surrounding areas, the services that the community is lacking, and what we are doing to help. Why we felt the need to work on adding services to the area, and community partners we have worked with. So there are some of the areas I do think contribute to patients not receiving mental health services when they need it. And when I look at this list that's up on the board, I do think that this can relate to more than just rural America, but these things listed also just make it more difficult in rural America because of the lack of access. So distance is a struggle, as we all know, regardless of where you are, because of a lot of us needing those services have barriers for transportation. And though there are many mental health providers in the area, I mentioned those wait lists, and for farmers and ranchers and other folks, it's just impossible for them to stop harvest and stop feeding the cattle and do whatever it takes to get to the appointments. So we have worked with HINC in the past on what we can do to get therapists maybe out in the field to help those farmers. And there's risks that come with that. You know, if there were to be a crisis and you're out in the middle of a field with a patient, what would that look like? There's just lots of ideas floating around on what we can be doing for them in rural areas. Back in the day when there were tough times, they just had to work harder and push through it. And this is still the case and carries over in today's day and age. And it does not make it does make it harder for people to accept help. When it is viewed as an illness instead of a weakness, the person is able to seek the help that they need as they would for medical needs. Many folks in rural areas do not have a lot of socializing options that do not include a bar after 5 o'clock. That's at least the case in our area. When people choose to drink, let me start over. When people choose not to drink to better their mental health, they are then feeling more isolated because they lose that social aspect in their life, and that's a big problem too. Sorry, I thought I saw somebody raise their hand. And then lastly on that slide, many families in rural communities are being forced to have one parent work from home because of lack of daycare resources. And this is the case everywhere, but in rural communities it's even worse. And which trickles into the families being able to afford health insurance to make their basic needs met. This also trickles into finances, and as they are able to, in their ability to be able to afford the cable and internet. So let's move forward on what we are doing to try to help these issues. It comes as no surprise from the pandemic that we have a rise in mental health needs in everybody from little children to elderly adults. We live in such a busy society, and women and men work and lead lives that leave little time to be alone and with themselves. And in the pandemic, this created situations that isolated people with their thoughts. They say, there is the saying that when you have your health, you have a million wishes, but when you don't have your health, you have one wish. And I do think that this holds true with your mental health. When things are okay and on the straight and narrow, you can neglect your mental health just by pushing through whatever the situation may be and not taking time to really sit with your needs and take care of yourself. This leads me to the thought that from the isolation of the pandemic, we were forced into our phones and technology, which was the only way to bring us together, but it continues to drive us apart. We have a more difficult time asking our neighbors and friends for help nowadays. Everything is at the click of a button, and though this is convenient, we need each other in order to thrive because humans instinctually need to feel cared for. Brene Brown, social worker and researcher, spends a lot of time on interesting topics, and one that stuck out to me was the concept of connection and how we don't connect the way that we used to. When things were harder, connection was easier. So from that, I do have the list of our community health needs results as of 2024, and it comes as no surprise that mental health is the second highest need. When I think about all of these, each and every one are affected by mental wellness. So what are we going to do to help? So through the community needs, Seneca Family Practice has partnered with Integrated Health Systems to provide virtual psychotherapy and medication management services to our patients. No referral is required, and patients and community members are able to call and schedule. We are very excited about this because it also allows us to reach patients that have a need and to help them to eliminate those barriers as we talked about earlier. We are connected with community partners, including area nursing homes and schools, to add therapy pods to the facilities for patients and children to have easier access to. Canceling sessions due to transportation issues, scheduling with school activities, and such is so common. And if it's in the facility that they are in and we are able to make it easier for them to access, I know that we will do better. We take pride in our staff and our ability to connect with patients. We offer the PHQ-9 depression screenings annually and as needed for patients' wellness visits. Our patients are also screened for DAST, which is the drug assessment, and then the audit assessment, which is the alcohol assessment, annually and as needed. Many times when patients come in for needs such as mental health, the needs present themselves as chronic health issues like frequent headaches or the inability to sleep at night or having low energy. It is easier to come out and say that you haven't been feeling like yourself lately than to say that you've been depressed. Knowing and recognizing signs and symptoms, asking the hard questions, all of these things help us to be catalysts to reducing the stigma and asking for help. We appreciate the continued support and services through our partnership with HINC. We have several staff members involved and on the HINC board for mental health services, including myself. This grant expands our ability to continue to provide great care to our patients and will affect generations to come. We also appreciate the support of KHA and the STEP Foundation, which is a local community organization that provides grants to our community for various needs. And one last thing that I did want to touch on is the ManHelp resource, which many of you have probably seen. They've been really trying to drive that in commercials and other areas, anywhere and everywhere. I don't know how I feel about the name of it. I know when I mentioned it to my husband, he was, but I do think that they had to figure out a way to reach that, reach them and figure out how we can help them without making them isolated in a way. It's hard for men to ask for help, and that was one way to do it. So they do have an online resource website. I didn't list it here, I'm sorry, but they do have online resources on their website if you guys want to check that out and add it to your resource lists within your agencies. And if you need any additional information on that, you could see me afterwards. Thank you.
Again, my name is Yasmin Wood. I serve as the CEO of Legacy Regional Community Foundation. So where you've heard clinical information, I'm really coming from a community face. It's not always typical for a community foundation to step into this kind of a role. However, we are very forward-thinking in how we can improve and sustain and grow our community. And we know that that is not something that's just transactional with donors giving a gift to the foundation, financially growing it, and then giving out grants and scholarships. We feel if we are involved in the leadership of the community and how those grants and scholarships are being deployed, that then we're going to be better stewards of the funds that our donors have trusted us with, and continue to be a partner in improving opportunity for our people. So that said, Legacy Regional Community Foundation also serves as the fiscal sponsor for our Community Health Coalition. It was started 25 years ago as a committee of a Vision 2020 plan. We wanted to really took a comprehensive look at what our community was like and how we might be able to move in particular areas to forward that. I wasn't at the Community Foundation at that time. The then leader, Pam Moore, was also involved in the Vision 2020 work, as I was from our Chamber of Commerce. So it was definitely a county-wide effort. But this is really what drives us a great deal toward the work that we do, that there really, truly is a divide that we heard over and over and over again in our community meetings by community leaders with regard to what we think we know, what we think our community looks like, and what actually is. And I tired very quickly of how people would, know their own industry, their own sector inside out, and the numbers upside down and backwards, but not be very savvy when it came to how it relates to others and other sectors and the holistic view of the persons and of the community. And so they would say things like, well, if they would just do this, not recognizing what the barriers might be or what obstacles might be in the way. And so we had an opportunity to, from the Community Foundation and with our stakeholders, step into that space. I started with a community foundation in June of 2016. So that first grant and scholarship cycle that we had in the winter of 2017, I talked with the people that had read those scholarship essays, and I said, what do you think? I'm thinking they're going to say, oh, we are so lucky to have such accomplished students in our community. And what they shared with me instead was their concern about the through line of anxiety and depression that was expressed by those students in their essays for the scholarships. And so that started me thinking, because if you present me with a problem, I'm like a dog with a bone, and I'm not going to let go of it until we get some action on it. And so with that, I started thinking about why. And if these students that were headed toward a continuing education were feeling like that, what about the rest of our young people? And so I have a background in theater and dance, not in social work or clinical psychology. But I thought about why that would be, and the fact that they maybe didn't have the vocabulary to express their emotions and think about them and feel them and explore them. And who did? Well, my theater kids did. And so we were able to develop some programming around that. But at the same time, fast forward just, another year and a half, and this is a headline in our local paper, Suicides Alarm Area Residents. We had 3 suicides in our small rural area. We have a county that's about 34,000 people in less than 5 months. There had not been a time where there had been 2 in a year prior to that. And so when our newspaper reporter did some investigative work with regard to this, some people threw up their hands and said, I don't know why this is, I don't know what could be. But we went to our community mental health center, and they serve multiple counties, and there was some insight there that attributed not only to the individual's state, but then the state of the community, and really looking at some of the risk factors, including the poverty in our community, the drug misuse, meth and opioids, family problems, access to social media and the violence that brings, as well as a lack of a relationship or a guidance in a people-to-people fashion. We have some groups in our community, as so many do, like the Boy Scouts and the 4-H and the Big Brothers, Big Sisters that provide mentoring, but we still found ourselves lacking. So you move forward through the pandemic, and we're already, like I said, trying to have these conversations and figure some things out. But the Community Foundation had an opportunity for a grant with the Mott Foundation and to look at how our work aligns with that of the Sustainable Development Goals of the UN. So it was kind of this perfect storm, because we started seeing how this work was dovetailing. We looked at what those sustainable development goals. We looked at the priorities that we had with our pathways to a healthy Kansas with the Blue Cross Blue Shield grant. We looked at the social drivers of health. And it was at this point that we were really raising up the question of equity and looking at things with a greater equity lens in our community. I already shared with you about my frustration with the people that said if they would just. And when I talked with my team that was brought together for those sustainable development goals, one of the things that we were charged with was carrying out, moving the needle on one of the goals in our community. So I had a split team. Half of them said childcare. Childcare is the biggest issue in our community. And I'm not satisfied, so I said, why? What about it? And we drilled it down to poverty and the sustainable poverty, the generational poverty that was happening in our community. The other half of the room said it was housing. We really, really had to address housing. And same thing, we drilled it down and it came back to poverty. Well, 20 years before that, when I was at the Chamber of Commerce, poverty was the big question, and no one had picked up that mantle in all of that time. So I asked them if they were ready to take that step. And so we determined that the thing that we wanted to address, the place where we wanted to move the needle, was on poverty. But then it was how. And so for us, it made good sense to go back to that question of people really understanding not who they thought we were, but who we really are, and looking at the data. And so with that, we felt like addressing poverty, it could raise a lot of judgment by people who maybe were not as informed. And we felt like if we looked at it through the lens of children and how it was impacting their lives, that we might be able to make more progress in a productive conversation. And so that's what we did. And we did that by holding a data walk. Now, naively, we thought if we held one data walk and put the information out there, everyone would just get it. And we would be able to move our community forward in a great way really quickly. Well, they got it, but they needed to see it again, and they wanted to bring more people into the fold, and they wanted others to be exposed to the information. And so we ended up, and I say we, Legacy Foundation, ended up hosting over 30 data walks in 2023. And that meant that we had people that were coming together, moving through stations with banners. The data was vetted by the Kansas Health Institute. It wasn't Yasmin saying, this is what is, and by the way, look at this. It was vetted. And it was looking at Cowley County as it was measured against the state of Kansas. And that was true with the exception of one, and that was that we looked at the concentrated disadvantage, going back to those risk factors we talked about: opportunity for education, access to healthy food, housing, and all of the issues. And our agent at the Kansas Health Institute said, I really think you want to look at this and how it measures against the United States. So I'm sharing with you today something that is not acceptable to me, and that is that in our Kansas City and in Winfield, which are our two largest communities in Cowley County, respectively, it is 99 and 95% more deprived than the entire nation. So you think about those intercity places that you maybe don't want to go on vacation, you skirt around, or those places that you hear in the news all the time, and we are equally or more challenged than 99 and 95% of them. So helping our community to see that and look at that and know has been very instrumental in growing the conversation about what we can do. So they looked like this. They looked like pastors and donors and community members and educators. They looked like schools, teachers, and they looked like students. We had student government, high achievers, with other students that were measurably more challenged. And we met with all of them and talked with them, shared the information with them, and then asked them for their thoughts. Two of the banners I wanted to share with you today because they seem most targeted for our conversation, and that is that banners around depression and suicide in Cowley County. And when I, as recently as last Friday, took the data walk again to one of the middle schools where they use it as foundational information for a social science fair that they do, they were again struck by the two things, one being that concentrated disadvantage, and on the other side, the suicide, and that 1 in 4 students in Cowley County have self-reported that they have made a suicide plan. So I shared with you my theater background and the opportunities that we have, and the fact that I work in community, and that you already know there aren't enough providers to reach everyone. So how do we change the conversation, and how do we help people to be in tune with the thoughts and the ideas and the ways in which they can help each other? This is a snapshot from a performance by one actor. His name was Shane Schrag. He actually happened to be a graduate of our Kansas City High School, on the stage at our Kansas City High School, doing theater in the round and show called Every Brilliant Thing. And Every Brilliant Thing is about an actor and how he deals with his mother's suicide attempts and ultimate act, as well as his own depression and anxiety. It wasn't enough just to do the performance and have it be a one and done. We had information that led up to that event and the teachers having the discussion. We couldn't get the 250 students all on the stage at the same time. We did them in groups of 50. And so what do you do with the rest of the students? So we had wellness days, and we had science teachers taking kids to the Humane Society to play with the kittens, and other people taking kids fishing, and other people doing yoga, and some of them learning how to crochet, just so that the teachers were humans and sharing their passions and their ways in which they find themselves an opportunity to de-stress. And so it helped in an immense way to move our community of our Kansas City forward. Since this time, we have 18 months later done the show again with a different actor and another opportunity, and we have set it up so that it's something that can go to other communities in our county and across the region in this state. The result of all of those data walks in 2023 was the creation of a group of folks coming together and focusing on a few focus areas that kept rising up to the top in those conversations. Not surprisingly, my team, my SDG team, was right. Childcare was a huge issue and concern for our community, as well as housing. And health had emerged over and over and over again as well. As this team has continued to distill where it is that they have an opportunity to work, it is in mental health that they are doing that. And a part of that work is not only supporting the Suicide Prevention Coalition and the Hope Squads, which are hand in hand in our schools, helping with peer-to-peer listening, but also with social connectedness. And we were able to garner another grant. We're 1 in 5 in the nation to get this grant to really look at the action guide and what its implementation might be in a rural setting. And then resource optimization. And this is really where all of you come in and where our partners come in, is that just like was already said, we can't do this alone. It's something that if we're all pulling in the same direction, the lift is easier and we can move ourselves forward. And so our community health needs assessment in the past has been something that was led by our local nonprofit hospital, the FQHC, and the City Cowley County Health Department. This year, these are the partners that have come on board because we've shared with them the value of this. We've shared for them the vision of how we intend to use this data and how we want to continue to build together in our work. So Cali X continues to do their work, but it is hand in hand with the Community Health Needs Assessment and the Community Health Improvement Plan. Rise Cali, for which we're the fiscal sponsor, continues to do their work and carry out that the same way, and implementing tools like the Prepare and using the ACEs. We have the school districts that's working with us. We have the health organizations that are working with us. We're working to really fully implement the Unite Us platform amongst us so that we have the communication that we need, and we've all pledged, not on paper, but to each other in our meetings, that we're going to meet people where they are and help to connect them not only to the resources that we provide, but the other opportunities and need, and own that problem. That goes back to my theater thing again. I spent a period of time working on a cruise ship, and I was an entertainer, and they didn't care if you were the person swabbing the deck, or you were the captain, or you the person that danced in the show. If someone presented you with a problem, you owned it until you were done. And that's how we're working in Cowley County. So this is some of the projects that have come out of that Cali Acts work already and our shared work in the community. And it only continues to grow every day. So thank you. And if I can be of any help, please reach out.
Thank you to all three of you for sharing some really great examples and a wide variety of examples of things that we can do to start to address these issues? Now, I have a couple questions, but before I jump into mine, I want to make sure we're addressing things that are of interest to those out in the audience. So do we have any questions out in the audience right now? Oh, I see one. Alice. Oh. Okay, well then I'll take this one off so that we can pass it back and forth.
Find it help. Yeah. Yasmin, thank you for that presentation. It was very fascinating. I'm curious, the research that you guys did that found Cowley or Arc City and Winfield 99 and 95, when will that be revisited to see progress?
So our intent is to revisit the data every 2 to 3 years. We're right due to that. But we've been kind of waiting for the community health needs assessment results also so that we have that information as well. So it's when we vetted, or when KHI vetted it for us, we asked them to all use open source data so we could go back. If I could get a pause in the work that the foundation is doing so that we went through a software conversion. I mean, it's just been nonstop. But that's our intent for early in 25.
Any other question? Oh, I see one up here.
Thank you. I'm interested in the data walk. We have posters that I'm from Sedgwick County Health Department, hi. And we did a data walk, and I'm now working with a group called the LHEAT, Local Health Equity Action Team, and we are playing around with the idea of taking our posters, those data walk posters, throughout the community. And so, first of all, are we going to get copies of your presentations, all of you? Thank you all. And secondly, what did that look like? Did you have full-size posters, and who did you use to take and present them, et cetera, et cetera?
So yes, and yes, and yes. We had banners that were on collapsible frames that we were able to take them to different places. The banners roll up, the frames, they go, and I can carry 10 of them at a time on my shoulder. So we were able to do that. We set up the stations. Most of the time, honestly, I was the facilitator. I had other people that would help me. Our very first facilitation, Ed O'Malley helped us out. And so it really, it looks differently in different times though. So you really have to think about who your group is and what you really want the outcome to be and what they want. So most of the time they were those full-blown 2-hour-long events that would go through, we had 6 stations, they'd go through half of them, we'd stop and say, what's surprising you? What are what's being raised up in your group? Then we'd go through the other ones and then do the same at the end. We were intentional in not having people there to explain the data. We trusted our group and felt like they were capable of reading the banners and coming to their own conclusions and being curious. And we challenge them to be curious, but to ask their own questions. But then other times when I went to the Rotary Club, they, have an hour-long lunch and eat. And so it would be something that was more 15 minutes, and they could choose a banner and then report out. And so it looks differently in different situations. The kids were the most amazing. Man, they called everything out. And one of the most powerful moments of all of those data walks was when one of the young people looked at the banner that was talking about single parents and saw themselves there and said, now I understand why my mom says the things she does. So they're going to tell you, and all of our data Our banners are on our Legacy website. And I am more than happy to talk with you and help you to think about all of those things. Give me a call, Legacy Regional Foundation, Winfield, and I'm there, or I'll get you my card at the end.
We do have a question on Zoom. I'm over here.
Okay, so really quick, just so in case folks didn't know, if you go to KFMC's website, you click at the top where it says Learn More About the Health Equity Summit. It'll take you to a page and you can get all the slides from every presentation today.
All right, the question on Zoom, and I'm not going to say the name, but I can connect later, is can we reach out to you to discuss on how medical and SDOH and mental health data can be connected to make the care coordination a better place?
So who is it for?
I think it's for all three.
All three?
If you want to clarify on Zoom, I can clarify.
Well, maybe while we're waiting for some clarification, just a little bit about how each of you maybe are working with community health workers and others in this, space of connecting folks to resources. We know the end result might sometimes be a behavioral health issue, but it probably could have started somewhere else.
So Southwest Kansas, we don't have a lot of community health workers at this time. That does seem to be something that's growing. Internally, we have care coordinators, which do some of what community health workers do. And we do administer the social determinants of health upon entry into our system and then annually, so we can then pass on to the care coordinators if someone is needing some assistance, and then they help track that down for the person. And we also use the Unite Us platform. So if you're not aware of that, it's very helpful for finding resources.
We do have a community mental health worker. I call it mental health because a lot of her referrals are mental health, but a community health worker and a care coordinator that deals with more of our chronic care patients. But in reality, they work very closely together because they have the same patients dealing with the same things. So anyway, our community health worker spends a lot of time she's shared between 2 hospitals, and she spends a lot of time working in the communities, creating referrals to areas that folks have no idea about, because in a doctor's appointment, when you go to a doctor's appointment for a backache, like your doctor's going to talk about your needs for your health, and who is going to talk to the individuals about other needs, such as like we talked about in other presentations today, like the needs for housing and the needs for mental health and just everything that can really affect your overall health. So we're really appreciative of her, and she is full-time, and I'm hopeful that we'll be able to maintain that grant-funded position and continue moving forward with that.
So a community health worker and a family navigator and a digital navigator and a care coordinator all have different titles, and all, I am told by our FQHC executive director, mean different things. But what they mean to me as a community member is that they're helping people. So we have a network of folks, and we have managed to begin to connect them with one another as well. And again, the Unite Us platform is a way in which we're working to do that. But we have them placed, we have a nonprofit organization called Eagle Nest that has a community health worker that came through the LHEAT and that work that we were doing there. The FQHC has a very broad panel of them. But one of the people that we've added most recently, just this fall, is a digital navigator. It's someone that is working through our public libraries. We have a shared position, and because not only do we want to help the organizations and those resources understand and know and feel comfortable with using the Unite Us platform, but we also know that people need to know how to use their smartphone or whatever other app or site is out there in order to access care. So they're all the same to me because they all care and help.
Okay, I know we have one more question, but in all of your packets, there's a flyer that talks about some state grant funds available for digital literacy, both for some help in getting digital navigators in your community and some other tools. So please take a look at that. Our last question is from Sarah.
This is probably a piggyback to the Zoom question, and it's probably for Lisa, because I think you might know the answer to this, you might not. So thinking about data sharing across settings, so behavioral health data, medical health data, and even some social service data. I know that I've talked to Family Service and Guidance about connecting to Health Information Exchange, and it was challenging for them. They really wanted the primary care data to serve their residents in behavioral health, but there are different rules about some of the mental health data. And that was not something that I think had been sorted out, and it's been a while. Is there any progress are you seeing community mental health centers connecting to the Health Information Exchange to be able to share that data back and forth? Sorry, that's a loaded question for the last one of the day.
And I was wondering if I'd see you today, Sarah. Okay.
I used to work at Compass when it was Area Mental Health Center with Lisa.
I don't know about that piece, but we have care coordinators that do get on KHIN every day to see if someone has been admitted to an emergency room or to a medical floor, and then when they're discharged, so that if there's someone that we're serving, we can reach out and try to be helpful to them.
Okay, we needed about 30 more minutes for this discussion. We ran out of time, but please join me, first of all, in thanking our three panelists for sharing their stories. I hope you all got some really useful information. Our planning group may talk about kind of taking these into some webinars and digging into some of this and more, because I don't think we got through everything that we were hoping we could discuss. But thank you all for being an engaged audience.